Welcome to this lecture on foot and toe pathologies. We're going to look at the foot as a functional region, not just a list of separate diagnoses. The foot accepts body weight, adapts to the ground, absorbs force, and becomes a rigid lever for push-off. Because of that, foot pain can quickly affect walking, running, jumping, cutting, and movement up the entire kinetic chain. As we move through the lecture, keep returning to three questions. Where exactly is the pain? What tissue is most likely involved? And what findings make this unsafe to manage without referral? The goal is not just to memorize conditions. The goal is to organize symptoms, mechanism, exam findings, and urgency the way a clinician would. These learning objectives frame our clinical approach. First, history has to be specific. A patient saying, "My foot hurts," is only the starting point. We need exact location, onset, mechanism, footwear, surface, training load, and medical risk factors such as diabetes, neuropathy, vascular disease, gout, or inflammatory arthritis. Second, we need to differentiate conditions that can look similar. Plantar heel pain, first MTP pain, forefoot pain, and midfoot pain each have different differentials. Third, we want exam selection to be purposeful. Do not perform random tests. Choose tests that answer the clinical question. Throughout the lecture, remember this mindset. Location matters, mechanism matters, footwear matters, medical history matters, and function matters. Use this overview figure to orient the region before thinking about individual diagnoses. A dorsal view helps you see toe alignment, swelling, deformity, and first MTP position. A plantar view helps you think about callus patterns, plantar fascia symptoms, sesamoid pain, and forefoot loading. Medial and lateral views help you assess arch posture, calcaneal alignment, Achilles position, and bony tenderness. The main point is that pain location drives the differential. Pain at the medial calcaneal tubercle is different from pain at the tarsal-metatarsal joints, and burning between metatarsals is different from skin or nail pain. Before naming a diagnosis, map the symptom: heel, midfoot, forefoot, first MTP, toe, skin, nail, nerve, or systemic. History is often where the foot evaluation becomes clearer. Start with past medical history because systemic conditions can change urgency. Diabetes, vascular disease, neuropathy, rheumatoid arthritis, gout, prior surgery, recurrent wounds, and immune compromise all matter. Then ask about the present condition. Have the patient point with one finger to the most painful area. Clarify whether onset was sudden, gradual, traumatic, or related to repetitive loading. Ask about the mechanism: push-off, inversion, axial load, forced toe extension, direct blow, or a recent training change. Footwear and surface are also important. Cleats, narrow toe boxes, worn shoes, turf, court surfaces, and new inserts can all contribute. Finally, ask about function: weight-bearing, push-off, gait, and whether symptoms are worsening. Inspection begins before hands-on testing. Watch the athlete walk if possible. Look at step length, stance time, push-off, foot progression angle, and whether they avoid loading a specific region. When appropriate, observe jogging, squatting, single-leg stance, toe walking, heel walking, or the task that reproduces symptoms. Then inspect posture and alignment: arch height, pes planus, pes cavus, rear foot position, Achilles alignment, toe alignment, swelling, bruising, and deformity. Always compare sides. Do not skip skin and nails. Calluses reveal loading patterns, blisters reveal friction, and nail changes or open wounds can change the plan. The clinical pearl is simple. The skin tells a story. Shoes often confirm it, and side-to-side comparison tells you what is meaningful. Pes planus and pes cavus are alignment patterns, not automatic diagnoses. A low arch or high arch can be completely asymptomatic, so the clinician has to decide whether the posture is flexible or rigid, painful or painless, and relevant to the complaint. Pes planus involves a lowered medial longitudinal arch and often more pronation or calcaneal eversion. In some athletes, that may increase stress through the plantar fascia, posterior tibialis, medial ankle, tibia, knee, or low back. Pes cavus is often more rigid and less shock absorbing, increasing focal load at the heel, lateral foot, metatarsal heads, or plantar fascia. For both foot types, connect posture to symptoms, footwear, function, and tissue irritability before making clinical decisions. This slide is about matching the assessment tool to the clinical question. If the question is arch behavior, navicular drop, longitudinal arch angle, or face line may help. If the question is rear foot or forefoot alignment, subtalar neutral assessment may be useful. If the athlete has first MTP pain, examine motion, joint play, stress testing, compression, distraction, plantar plate tenderness, and sesamoid involvement. That helps separate turf toe, hallux rigidus, capsular sprain, sesamoid problems, and arthritis. If symptoms sound neurologic, use sensory mapping, Tinel sign, and nerve provocation. If metatarsal pain is focal and load-related, consider fracture or bone stress injury and avoid aggressive testing. Tests should answer a question, not just fill time. This section begins heel and plantar foot pain. Heel pain is common, but it is easy to oversimplify. Plantar fasciopathy is common, but it is not the only possibility. The differential includes plantar fascia irritation, calcaneal apophysitis in younger athletes, calcaneal stress injury, fat pad irritation, nerve entrapment, Achilles-related symptoms, and referred pain. Use the symptom pattern to guide your thinking. Is pain worst with first steps in the morning? Is it progressively worse with impact? Is there burning or numbness? Is the athlete in a growth period? Is there focal bony tenderness or pain with squeeze testing? Heel pain becomes clearer when the story, location, age, and loading pattern are matched to the likely tissue. Plantar fasciopathy usually has a recognizable pattern. The athlete often reports medial plantar heel pain that is worst with the first few steps in the morning or after sitting. It may loosen as they move, then return with running, practice, or prolonged standing. On exam, tenderness is often near the medial calcaneal tubercle and proximal plantar fascia. Also assess ankle dorsiflexion, calf flexibility, great toe extension, foot posture, footwear, training volume, and surface changes. Early management should focus on load modification, not just rest. Options may include calf and plantar fascia mobility, intrinsic strengthening, taping, orthoses, and footwear adjustments. Refer if the case is traumatic, atypical, severe, neurologic, or not responding as expected. Tarsal tunnel syndrome is a nerve-related presentation, so the patient's language matters. Burning, tingling, numbness, paresthesia, or symptoms traveling into the plantar or medial foot should move your thinking toward tibial nerve irritation or compression. Symptoms may increase with prolonged standing, excessive pronation, swelling, prior ankle trauma, or dorsiflexion eversion positioning. The exam should include sensory comparison, Tinel sign over the tarsal tunnel, dorsiflexion eversion provocation, toe flexor strength, foot posture, and medical risk factors. Differentiate this from plantar fasciopathy, posterior tibialis tendinopathy, lumbar referral, peripheral neuropathy, and calcaneal stress injury. If symptoms are progressive, atypical, vascular, or linked to systemic risk factors, refer. Posterior heel pain in a youth athlete should raise the possibility of calcaneal apophysitis, or Sever disease. This is traction irritation at the calcaneal growth plate, often during growth periods with running, jumping, and cleated sports. Ask about growth, load, footwear, surface, and sport demands. In contrast, calcaneal stress injury is a more concerning bony diagnosis. Progressive heel pain, load intolerance, pain with impact, focal bony tenderness, and pain with squeeze testing should increase suspicion. Do not dismiss youth heel pain as just growing pains, and do not dismiss adult heel pain as routine soreness. Ask whether this is apophyseal traction, bone stress injury, soft tissue overload, or systemic concern. When fracture or bone stress is suspected, protect and refer. This section shifts to midfoot and forefoot trauma. These injuries can be deceptive because serious problems may not look dramatic early. Moderate swelling with the wrong mechanism and pain location can still indicate a high-risk injury. Midfoot and forefoot injuries may involve metatarsals, tarsometatarsal joints, sesamoids, plantar plate, joint capsules, or the first MTP complex. Mechanisms include axial loading, twisting on a planted foot, forced dorsiflexion of the great toe, direct contact, inversion injuries, and repetitive overload. Pay close attention to weight-bearing status, exact tenderness, swelling, bruising, mechanism, and pain with push-off or forefoot loading. If fracture, Lisfranc injury, significant first MTP instability, or bone stress injury is possible, protect, document, and refer. Metatarsal fractures and stress injuries can come from acute trauma or repetitive overload. The athlete may describe a direct blow, rotational injury, inversion with lateral foot pain, or training increase that created a bone stress response. The key feature is focal pain. Pain along a metatarsal shaft or base that worsens with weight bearing, hopping, forefoot loading, or running should make you cautious. Look for swelling, point tenderness, progressive symptoms, and risk factors, such as rapid load change, hard surfaces, footwear changes, foot posture, Morton toe, or low energy availability. Avoid aggressive stress testing or massage when fracture is suspected. Protect weight bearing, immobilize when needed, refer for imaging, and document mechanism, tenderness, swelling, and neurovascular status. A Lisfranc injury is one of the major do not miss conditions in the foot. It involves the tarso-metatarsal joint complex and can occur with high-energy trauma, axial load through a plantar flexed foot, or twisting on a planted foot. The athlete may report midfoot pain, swelling, difficulty bearing weight, and pain near the first and second metatarsal or cuneiform region. Plantar ecchymosis is a major warning sign when the mechanism fits. Do not treat this like a simple sprain and wait to see what happens. Subtle instability can be missed, and delayed recognition can lead to chronic pain, arthritis, and poor return to play outcomes. The mindset is simple. Concerning midfoot mechanism plus pain equals protect and refer early. Turf toe is a first MTP sprain, usually from forceful hyperextension during push-off on a planted forefoot. It is common in athletes on firm surfaces or in shoes that allow excessive forefoot motion. Pain is usually at the plantar aspect of the first MTP joint and worsens with toe extension and push-off. Examine swelling, bruising, range of motion, plantar plate tenderness, sesamoid tenderness, varus and valgus stability, weight-bearing, and push-off ability. Severity ranges from mild capsular sprain to significant plantar plate disruption with instability. Management may include protection, taping, stiff-soled footwear, or a carbon insert. More severe injuries may need immobilization and referral, especially if there is instability, fracture concern, or inability to push off. The sesamoids sit under the first metatarsal head and help transmit force during push-off. They are heavily loaded during sprinting, jumping, dancing, cutting, and forefoot-dominant activity. Sesamoiditis usually develops gradually from repetitive loading or repeated first MTP extension. Pain is located beneath the first MTP joint and worsens with push-off, toe extension, or direct pressure. Sesamoid fracture should be considered after acute trauma, sudden focal pain, or severe pain with weight bearing. Examine the medial and lateral sesamoids, first MTP motion, flexor hallucis longus and brevis function, gait, and footwear. Offload the painful area early and refer when symptoms are severe, traumatic, persistent, or when fracture is possible. This section moves from trauma to toe alignment, degenerative change, and footwear-related pathology. Toe deformities may seem minor, but they can change pressure distribution, create calluses, irritate skin, limit shoe tolerance, and alter push-off mechanics. Ask whether the deformity is flexible or rigid. Flexible deformities may respond to footwear changes, padding, taping, spacers, or strengthening. Rigid or progressive deformities require more caution, especially with skin breakdown, neurologic involvement, or worsening pain. Footwear is a major contributor. Narrow toe boxes, stiff materials, cleats, and shoes that bend in the wrong place can worsen symptoms. The clinical question is whether the alignment is painful, progressive, limiting function, or placing skin and joints at risk. Hallux valgus involves lateral deviation of the great toe with medial prominence at the first MTP joint. Clinically, think beyond appearance. The patient may report medial first MTP pain, redness, bursitis, shoe irritation, pressure between the first and second toes, or pain with push-off. Risk factors include genetics, footwear constraints, foot posture, first-ray hypermobility, and repetitive loading. Conservative care focuses on symptoms and function, not forcing the toe into perfect alignment. Management may include a wider toe box, padding, toe spacers, taping, orthoses when appropriate, and load modification. Refer for severe deformity, progressive pain, skin breakdown, neurologic symptoms, or failure of conservative management. Protect skin and assess footwear carefully. Hallux rigidus is stiffness and pain at the first MTP joint, especially with extension. This matters because great toe extension is essential for efficient push-off during walking, running, jumping, and cutting. If the joint cannot extend, the athlete may turn the foot outward, shorten stride, shift load laterally, or avoid full push-off. On exam, look for reduced great toe extension, dorsal joint tenderness, pain with joint play, possible osteophyte irritation, and altered gait. Compare sides. The differential includes turf toe, sesamoiditis, hallux valgus, gout, and first MTP arthritis. Management often reduces painful extension through stiff-soled footwear, carbon inserts, activity modification, and symptom control. Persistent limitation or progressive pain should be referred. This comparison slide separates claw toe, hammer toe, mallet toe, and Morton toe. Claw toe typically involves MTP hyperextension with PIP and DIP flexion, often creating dorsal irritation, distal pressure, callus formation, shoe pain, and sometimes neurologic or muscle imbalance concerns. Hammer toe involves PIP flexion with relative extension at the MTP and DIP joints, commonly causing dorsal PIP irritation and shoe conflict. Mallet toe focuses on DIP flexion, which can increase distal toe pressure and nail irritation. Morton toe is different. The second toe appears longer, often because the first metatarsal is relatively short. That may alter forefoot loading. For all patterns, check flexibility, skin, footwear, pain, and functional limitation. Morton neuroma and metatarsalgia are both forefoot pain presentations, but they are not the same. Morton neuroma usually involves interdigital nerve irritation, commonly between the third and fourth metatarsal heads. The athlete may describe burning, tingling, numbness, radiating toe symptoms, or the feeling of walking on a pebble. Metatarsalgia is broader and describes pain beneath the metatarsal heads from overload, footwear, altered mechanics, reduced cushioning, callus formation, or training volume. The exam may include interspace palpation, metatarsal squeeze, Mulder sign, toe sensation, callus inspection, footwear assessment, and gait analysis. Keep the differential open. Stress fracture, plantar plate injury, capsulitis, callus, and tarsal tunnel syndrome can overlap. Plantar plate injuries and capsulitis are less obvious forefoot conditions that can be missed. The plantar plate stabilizes the lesser MTP joints, especially the second MTP joint. When irritated or torn, the athlete may report pain beneath the joint, swelling, instability, toe drift, or pain during push-off. Capsulitis can look similar early, with joint line tenderness and pain during MTP motion or loading. Consider these conditions in athletes with repetitive forefoot loading, sudden overload, hallux valgus, toe deformity, or increased metatarsal head pressure. Ask whether the joint is stable, whether pain is plantar, whether the toe is drifting, and whether the athlete can push off. Persistent pain, instability, deformity, or suspected tear should be referred. This section reminds us that skin, nail, and medical history matter in foot evaluation. These findings are not side issues. They may be the reason an athlete cannot participate, or they may signal infection, pressure overload, footwear problems, hygiene concerns, or systemic disease. A blister may seem simple until it becomes infected. A callus may reveal repeated overload. A plantar wart may mimic a painful callus. An ingrown nail may prevent cleat tolerance. An open wound in someone with diabetes or neuropathy is not routine athletic training room management. Think about scope, safety, and referral. The foot is exposed to sweat, friction, shared surfaces, tight footwear, and repetitive loading, so inspect carefully and treat infection signs seriously. Calluses and corns usually reflect repetitive pressure or friction. They can show where the athlete loads the foot and whether footwear contributes. For example, callus under a metatarsal head may support a story of focal forefoot overload, while a corn over a toe joint may suggest shoe conflict or toe deformity. Blisters are usually friction-related, but they still require protection, hygiene, and monitoring for infection. Plantar warts can be painful with direct pressure and may mimic callus, but they often interrupt normal skin lines. Management should reduce pressure and friction, protect the skin, and address contributors such as footwear, socks, movement, or training load. Refer for atypical, infected, worsening, recurrent, or high-risk lesions. Nail conditions can strongly affect sport participation because shoes and cleats place direct pressure on the toes. An ingrown nail can cause pain, redness, swelling, drainage, and poor footwear tolerance. Onychomycosis can create thickening, discoloration, brittleness, and shoe irritation. A subungual hematoma can follow direct trauma or repetitive shoe pressure and may be very painful. Look for infection signs, drainage, increasing redness, nail bed trauma, and fracture risk after a direct blow. Ask whether the athlete can wear sport footwear comfortably and whether symptoms are worsening. Management may include protection, reducing shoe pressure, hygiene, and monitoring. Refer for infection, severe pain, nail bed injury, recurrent ingrown nails, diabetes-related risk, or suspected fracture. This slide highlights systemic conditions and red flags that can mimic musculoskeletal foot pain. Gout may present as sudden, severe joint pain, often at the first MTP joint, with redness, warmth, swelling, and extreme tenderness. That can be mistaken for turf toe, arthritis, or trauma if the history is incomplete. Infection is another major concern. Spreading redness, warmth, drainage, fever, open wounds, disproportionate pain, or systemic illness should immediately increase urgency. Diabetes, neuropathy, vascular disease, immune suppression, and open wounds raise concern even more. Do not assume every red, swollen first MTP joint is turf toe. Refer now for fever, spreading redness, drainage, open wound, neurovascular compromise, unexplained severe pain, or systemic illness. This matrix organizes foot pain by location, which is one of the fastest ways to narrow the differential. Medial plantar heel pain points toward plantar fasciopathy, heel spur irritation, calcaneal stress injury, or fat pad syndrome. Medial ankle or plantar numbness suggests tarsal tunnel, posterior tibialis involvement, or neuropathy. Midfoot pain after twist or axial load raises concern for Lisfranc injury, tarsal fracture, or midfoot sprain. Lateral foot pain at the fifth metatarsal base could be avulsion fracture, Jones fracture, peroneal tendon issue, or lateral ankle sprain. First MTP pain may be turf toe, hallux rigidus, hallux valgus, gout, or sesamoid involvement. Use location first, then ask targeted questions and choose focus tests. Red flags and referral triggers are the safety checkpoint for the lecture. If the athlete cannot bear weight, has severe deformity, has suspected fracture or dislocation, or sustained a significant midfoot mechanism, think protection and referral. Neurovascular compromise is also urgent. Numbness, weakness, absent pulses, delayed capillary refill, color change, temperature change, or symptoms that do not match a simple injury pattern should be taken seriously. Open wounds, spreading redness, drainage, fever, systemic illness, diabetes-related foot concerns, and immune compromise increase urgency. The action plan is straightforward. Protect, immobilize when needed, restrict activity, refer, and document clearly. When you are unsure about safety, stability, or medical seriousness, referral is the correct decision. Let's apply this to a heel pain case. A 20-year-old football athlete has persistent medial heel pain. Pain is worst with first steps in the morning and increases again during practice. There is no swelling or ecchymosis. Tenderness is over the medial calcaneal tubercle, and ankle dorsiflexion is limited. This pattern strongly supports plantar fasciopathy because the location, first step pain, and loading response all fit. Still, rule out important differentials. Ask about focal bony pain, worsening impact pain, burning or tingling, recent trauma, systemic symptoms, and progressive worsening. Management this week might include reduced high-impact volume, calf and plantar fascia mobility, foot intrinsic work, taping, supportive footwear, and symptom monitoring. Refer if atypical, severe, traumatic, neurologic, or non-responsive. Now consider the midfoot trauma case. A softball athlete lands awkwardly with the foot caught and reports pain near the first and second metatarsals and cuneiform region. Weight-bearing increases pain, compression reproduces symptoms, and the neurovascular exam is normal. A normal neurovascular exam is reassuring, but it does not rule out a serious midfoot injury. The mechanism and location should raise concern for Lisfranc injury or another tarsometatarsal injury. Plantar ecchymosis would increase suspicion even more, along with difficulty bearing weight, focal midfoot tenderness, swelling, and pain with forefoot stress. If suspicion is high, stop aggressive testing, protect the foot, restrict activity, refer for imaging, and document mechanism, pain location, weight-bearing status, and neurovascular findings. Management across foot conditions should match the involved tissue, severity, irritability, and healing stage. A suspected fracture, unstable first MTP injury, significant midfoot trauma, or infection concern is not managed like mild plantar fascia irritation or a footwear blister. A useful progression is protect, calm symptoms, restore motion, build strength and control, reload tissue, and return to sport demands. Protection may involve immobilization, taping, footwear modification, offloading, or activity restriction. As symptoms improve, address mobility, strength, balance, gait, foot intrinsic control, calf capacity, footwear, surfaces, training errors, and recovery. Return to activity should be guided by pain response, function, sport demands, and objective criteria, not time alone. The key takeaway is that foot and toe evaluation must be specific. Pain location leads the exam. When you know whether symptoms are plantar heel, posterior heel, midfoot, lateral foot, first MTP, forefoot, skin, nail, or nerve-related, you can narrow the differential and choose better tests. Mechanism changes urgency. Gradual heel pain after training changes is different from midfoot pain after twisting axial load. Inability to bear weight, plantar ecchymosis, focal bony tenderness, suspected fracture, infection signs, and neurovascular changes should shift the plan toward protection and referral. Management is load-based. Footwear, surface, volume, mobility, strength, gait, tissue tolerance, and medical history all matter. We are not just naming diagnoses, we are making safe decisions. These references support the major concepts from the lecture, including plantar fasciopathy, common foot problems, bunions, ankle and foot examination principles, and orthopedic assessment. Encourage learners to use references as part of clinical reasoning rather than as an afterthought. When you are uncertain about a diagnosis, referral threshold, or rehabilitation progression, return to high-quality sources and compare the literature with what you are seeing in the patient. To close, remember that the foot may look like a small region, but it carries a major clinical responsibility. A strong evaluation combines history, location, mechanism, inspection, palpation, selected testing, medical screening, and sound judgment about referral and return to activity.